licensed clinical health psychologist and board-certified behavior analyst. He is an OEF veteran and a former Air Force officer, having over 15 years of research, teaching, and training experience in university and medical settings. Dr. Corso currently holds an adjunct assistant professor position in the Department of Family Medicine at the Uniformed Services University of Health Sciences and has published over 15 peer-reviewed articles. Over the last decade, he has developed and managed several primary care behavioral health programs for the military health system. As a subject matter expert for the Department of Defense, he currently supports clinical and business operations at the National Capital Region Medical Directorate, which enrolls over 137,000 patient beneficiaries. As president of NCR Behavioral Health, Dr. Corso leads an international training and consulting group for private and federal healthcare organizations in pursuit of integrated behavioral health programs which apply population health principles and cutting-edge models to improve patient health and return an investment to the system. He is the lead author of Integrating Behavioral Health into the Medical Home, a rapid implementation guide, which is a new book from Green Branch Publishing. Join me in welcoming Dr. Corso.
Thank you so much, Dr. Cortez, for that introduction, and thank you so much, Polly. Why don't we go ahead and get going? I've got probably more slides than we have time for, but that's okay. My understanding is that the video of the webinar will be available on the CFHA website for future viewing. So with that, assessing suicidal patients in the PCBH model, primary care behavioral health model, here are our learning objectives. We're going to explain the roles of the primary care team members in helping to address suicide, help the attendees describe how to do a risk assessment, especially within the brief model, and how to create effective crisis response plans suitable for the PCBH model. In preparing this webinar, I've left out some of the slides I would typically include that have to do with the rationale for addressing suicide in primary care. These are available elsewhere, and the statistics are out there, but there is often a challenge in convincing the primary care leadership that having a whole separate screening process just for suicide is worthwhile. And these prevalence rates can be helpful if you do run into that in your own practice where you're working. The reality is that for suicidal ideation and behaviors in general medical settings, the prevalence ranges from 2 to 5%. For patients prescribed psychotropics, it's 22%, and of course we know that up to 80% of psychotropic medications for depression are prescribed by a non-psychiatry provider, and around 60 to 70% of those are in primary care. So chances are that primary care providers are going to see patients who are suicidal. In one study that we conducted in 2008, the prevalence in PCBH model was about 12%. So this is something that we will see as behavioral health consultants. Of course, there are estimations that 1 to 10% of primary care patients will experience suicidal symptoms at any given time. Suicide continues to be among the top 10 causes of death each year in America. And some other interesting facts that again, can be helpful as we try to gain buy-in from our PCMH stakeholders is that of the individuals who die by suicide, 45% visit their primary care provider within 1 month. 20% of those who die by suicide visit their primary care provider within the last 24 hours. And among the elderly, that statistic is much higher. So if you are working in a geriatric PCMH or a PCMH that is internal medicine and the population may be older, it is even more important in those settings. And when we look at the complaints of the patients who died by suicide immediately preceding their visit, the clinical problems that they presented include the following: depression, anxiety, and then 3 non-mental health areas of concern. So this is often one of the important factors that we share with our stakeholders to help them understand that if we only ask about suicide during a patient visit, if they're here for depression or anxiety or some other mental health problem, we technically end up missing 60% of the people who will leave the appointment and eventually die by suicide. We also know that suicidal patients report poorer health, and they visit medical providers more often than those without suicidal symptoms. We also know that medical visits increase in frequency in the weeks preceding someone's death by suicide. So when we consider that the patient-centered medical home involves team-based care, we have to consider how to leverage that team in order to address these severe issues. One of the concerns that providers and nurses often have is that there are hundreds of other diseases or conditions that they are responsible for tracking and monitoring and screening, and that they just don't have time for one more condition, such as suicide. And a helpful response to that concern that I've often used is that I can't think of any other condition that is fatal that can be screened and assessed by asking one question. And asking that question is inexpensive, and it certainly does not take a lot of time. And so it goes without saying that the nurses and medical assistants are sort of the prime candidates for conducting suicidal screening. Oftentimes this may happen in the room or at the juncture in the medical appointment where vitals are taken. That's whether it's through the computer the electronic medical record, or whether it's on a piece of paper that is prepped for each patient and handed to the primary care provider. So nurses and medical assistants play a vital role in the screening process, and then in also coordinating care when the patient needs something more. So for example, if the patient is screened and the medical assistant or nurse finds a positive screening, then the patient happens to be walked into the PCP, and the PCP talks with the BHC, the behavioral health consultant, and says, you know what, we need to hospitalize this person. The nurse and medical assistants may be coordinating care and helping facilitate things like transportation to an emergency department, sitting with the patient if the patient is actively suicidal and therefore needs to be hospitalized. So things like that. The role of the primary care provider, of course, is to follow up, conduct follow-up assessment, and determine risk in an ongoing way. We'll talk about that a little bit later this afternoon when we discuss and how to look at suicide in relation to other conditions in one's medical background. The PCP will be responsible for doing a warm-up to the behavioral consultant and, of course, managing medication. So, for example, there's a patient who's currently on, let's say, antidepressants, and the PCP treating this person how they are suicidal. He may choose to either increase medication or add medication, also doing a warm handoff to the behavioral health consultant. Which brings us to the role of the behavioral health consultant. The role, we can't transport a specialty level of suicide in a sense to primary care domain. It neither fits nor is it doable considering the other instance. And so primary role is to assess risk and determine this position. Also, intervention transition or bridge patients to a specialty mental health. For example, if we have a patient who doesn't require hospital, but an outpatient psychotherapy provider, whether that has to wait or whether the person is available in 7 days. We may touch base with the patient phone. We may see the patient back for a brief bridge sort of appointment. And in that appointment, we're similarly going to reassess assess risk and disposition, but then we may do the crisis response plan and try to help them devise any other strategies for coping that they can utilize. But here's for a moment talking fluid vulnerability theory to consider this how we are traditionally trained in a specialty outpatient mental health clinic. Suicide risk is comprised of two different dimensions. Baseline dimension, which is an individual set point for risk dispositions, things like gender, that traditional dimensions, and these are short-term or current risk based on any aggregating variables and other protective factors. We might also, that is a status. And so if we consider that fluidity theory, everyone has some sort of a baseline risk, and as life goes on, that risk may increase. And so if we examine it as a chronic disease management model, much like other chronic disease management models, we'll see periods where it will be worse and periods where it will be better. Although what we do know from the literature is that suicide risk tends to be progressive over time. And so the role what happens between those ends. And so we have a patient level or direct impact on suicide risk, and that's by providing the behavioral health consultation that we can provide in the context of population impact on suicide risk, which is that you're handling the population of patients who may have suicidal episodes. We're handling them at a population level and bringing a standard level of we have to think about it differently than if we were working in a specialty mental health setting. And another footnote that's very important is that multiple attempters will require extra interventions and ongoing monitoring, and we'll get to that in a moment. So just a helpful point here that is especially helpful in outpatient psychotherapy or outpatient mental health settings, but should also be adopted in the primary care setting, is that it can be easy to form a me versus you or an us versus them sort of a stance or dynamic with suicidal patients. And this is particularly heightened in primary care, where we have less time and we may be more quick to assess exactly what's going on and figure out the disposition due to the time crunch and the multiple demands and juggling that tends to happen in primary care. So we have to remember to reinforce help-seeking behaviors and encourage more help-seeking behaviors and validate help-seeking behaviors, while also ensuring that we are truly looking out for the patient's safety. Now, just a note about that, historically, both mental health providers and primary care providers will either underestimate risk or overestimate risk. And we want to strike a middle ground and a balance. We can't have the threshold be so low that we knee-jerk react and try to hospitalize someone for every single suicidal incident that arises. Essentially, that communicates to the patient that they are not in control of themselves and that they are not capable of managing this, and that something has to be done for them because they could kill themselves in an instant. And so it's very important to communicate to them empowerment, and well, to empower them and to communicate to them that help is available and it works, and that the more that they can manage these thoughts and feelings, the better the symptoms will get. If you're looking for further information about this approach, look up David Jobs' work. It's the Collaborative Assessment and Management of Suicide. It's incredibly helpful, evidence-based work that anyone who ever sees a suicidal patient, as far as mental health providers go, should be familiar. This sounds like common sense, but don't try to talk the patient out of killing themselves. If anyone in the audience is familiar with the stages of change theory and motivational interviewing, suicide is no different. It is a state of ambivalence. Suicidal patients have reasons for living and reasons for dying. And superimposed on top of those reasons and that logic are a whole host of emotions. And those emotions, of course, as we know, impact their judgment, impact their impulse control, impact their ability to process information so that they may see things far more negatively than things actually are, or they may underestimate the probability of positive things happening and overestimate the probability of negative things happening. And so they're in a state that they might be impressionable and we can persuade them during an appointment, but when they leave our office, that goes away. And so talking patients out of killing themselves is an ill-advised approach. It does take a little bit of explanation to help differentiate what this means, but my hope is that as we go through the next several points, it will become clear. So respect the patient's autonomy and ability to kill themselves. Don't moralize it. Avoid using the word commit suicide. Commit is value and judgment laden. It is often, patients often connect it with the idea of committing a sin. And that's not helpful when trying to collaborate with the patient. And the other piece about being collaborative is that if the patient very quickly is clear that you could hospitalize them, especially outside of their will, if you're in a state that allows that, they will absolutely limit or change what they tell you. So do your best to to avoid power struggles about options. And if you're doing that, you will at the same time be increasing your threshold hospitalized. Just a footnote here, there are no trials that demonstrate that immobilization reduce suicidal symptoms. There is evidence that it may reduce suicide, attributed to increased supervision, increased medication. There's also a non-specific effect having to do with being in the attention and under the care of a team, and also the removal of means to die by suicide. And so many people, and especially may be inclined to believe that psychiatric hospitalization sort of is the best decision if there's any doubt as to the patient's risk, because at least they're safe, is discharged from that setting. The suicidal symptoms themselves specifically, they may resolve or they may decrease, but they have not been addressed directly. They have not been targeted. And so there are times where you will ask for that very reason. Eliminate psychobabble, complex theories for both patients and for the PCPs. Your role in this setting is to really be a good team member and to bridge your team. Use language that is both non-medical and non-jargon. It's got to be simple. Explain the concept or to the team or the patient, or teach a skill in 5 minutes, then it's probably too complex. And lastly, your strategies have to be evidence-based. One other, since we are working with other professionals of other disciplines, especially if we're in the same record or EHR, the words we use need to be chosen so that they communicate the same thing every time and so that all team members understand. So suicidal attempt is an intentional, self-enacted, potentially injurious behavior without any eye, whether they're injured or not. Non-suicidal self-injury is intentional, self-enacted, potentially injurious behavior with no intent to die, with or without injury. So an attempt has some amount of intent to die. Non-suicidal self-injury has zero intent to die. And it doesn't really matter whether in their injure themselves. Suicidal ideation is thoughts of ending one's life, enacting one's death, or somehow being involved in facilitating one's death. Non-suicidal morbid ideation is defined by thoughts about one's death. So these could be what we sometimes hear as morbid thoughts with suicide, without suicidal or self-enacted injurious content. So this is where someone says, you know, I've thought about what it would be like if I just did, or I thought about what it would be like if I could just go home and sleep forever. Those are non-suicidal morbid ideation. I clarify that when you are the clinician seeing that patient. The key here is, does the patient see himself or herself as playing her death? And we'll touch on that again in a moment. Eliminating the following terms from your vocabulary and particularly from your documentation: suicide gesture, parasuicide, suicide threat, self-mutilation, commit suicide, other terms that are not under help. The problem with those terms, take a cry for help, for example, is when people hear a cry for help, they, for some reason, seem to become less concerned about the patient, which is unfortunate, because just because it's a cry for help doesn't mean it's not a serious matter and a legitimate symptom to be addressed. And the other terms on this slide, reason why they're not so helpful is they don't really tell us anything about the severity of the symptom and or what to do about the symptom or the behavior, the prognosis for that behavior. So And a few words about non-suicidal self-injury. This can also include cutting, branding, and burning. We certainly see those behaviors, and oftentimes people say, or patients will report, that they feel emotionally numb, but if they physically harm themselves, then it at least enables them to feel something. Some patients report that they feel sort of an emotional release or a release of tension. So just want to point that out. Those count as non-suicidal self-injury. Accurate and brief risk assessment. Well, first let's start with screening. We know that screening is important because only 17% of patients suicidal ideation on pencil and paper screeners actually disclose this to PCPs. In other words, patients are unlikely to just disclose it out of the blue unless we ask. And if we ask by paper and pencil, we will identify more patients than we otherwise would have. 6% in one sample, 6.6% of depressed patients endorsed suicidal ideation or death ideation on a PHQ-9, and positive screens actually had suicidal ideation when they did further examination, and 20% of those had a plan. So these patients are there. We are likely going to miss them. Potential survey screening methods. These 5 instruments can be helpful. I'm not going to read through each of them, but what I will say is that the Columbia Suicide Severity Rating Scale does stand out in contrast to the other instruments, and it stands out because it specifically differentiates between suicidal ideation and non-suicidal morbid ideation. All of those other 4 instruments do not clearly differentiate between the 2 behaviors. So a practical way of saying this is you're asking something much more specific and helpful in discriminating what the patient is experiencing and what the patient needs from his or her medical care instrument compared to the others there that demonstrate that. Even reading the items, you can see that. Within the Department of Defense, there was a recent study. It's unpublished data, but it was done comparing the Columbia with the advantages are clear to using the Columbia. It's just more accurate. So I'd encourage you to use that instrument for screening and for ongoing monitoring of how the patient's suicidal symptoms are either improving or exacerbating. And no matter which approach is adopted, suicide screening should become a part of routine patient evaluations, whether they have a mental health condition or not. Why would I suggest that? Of course, it's because it goes back to that point, that research on the reasons that people are seen in primary care in the visit prior to their death by suicide. And 60% of the complaints had nothing to do with the mental health condition. And so we will lose the opportunity to identify those patients and care for them. Also, when you're screening in the context, let's say someone is there for a diabetes appointment with a care provider, and then you and now they have to see you for suicidal thoughts, even though they were here for diabetes. Context and educate them. So good examples are many times when people feel whatever about death or have thoughts about suicide. Do you ever wish you were dead or think about killing yourself? Another way to say this in a screening scenario to help patients understand where you're coming from is to very calmly and confidently educate them. Some folks would say, well, we're asking this question because we know that even when people are feeling suicidal, they still come in and medical conditions. So I'm wondering, have you had any thoughts in the last 2 weeks of ending your life or killing yourself? So again, the more comfortable and confident we are in approaching this, the more comfortable about responding. And they absolutely read cues from us, and the more we treat it like any other medical condition, and any other medical screenings, such as how much do you weigh, how tall are you, the more effective we are. So here's a table from a book that lists all of the factors associated with increased risk for suicide. And I love showing this because it really, I think, resonates with most behavioral health consultants who are sitting back and saying, how in the world do we synthesize all the possible information that we can gather from a patient and from a medical record in order to make a risk assessment in a 20-minute appointment? The first answer is you must read the medical record, and you absolutely cannot skip reviewing patients' medical records within the PCBH model. In my opinion, it's a bad habit in the specialty mental health domain, and if we carry over that bad habit of not reading the medical record in the primary care domain, we provide poor care to our patients. And so if we look at these 147 factors, how do we know how to sort of distill them down? Well, think of this in terms of proximal versus distal risk factors, something that happened 20 years ago versus an experience that happened last week. The patient had a divorce, their parents divorced 20 years ago, and it was a horrible experience for them, versus they lost their job last week. Oftentimes it's the more proximal risk factors that are playing a role in current emergence of suicidal symptoms. Now, there's a very specific assessment approach that we recommend you use in PCBH, and it has 5 factors here. And they sort of take a triage approach. They're intended to be used so that you don't ask questions which are not really going to determine your outcome, and that the questions you do ask are predictive of risk. They're not just gee whiz questions that help paint a richer picture. So first start with screening. Then the task as a BHC is to differentiate suicidal ideation from non-suicidal morbid ideation. Then we assess for past suicidal behaviors, and if there is a positive history of prior attempts, we assess those attempts before assessing the current episode. And then finally we screen for protective factors. In 2009 we published an article about this in Professional Psychology Research and Practice. This is an excerpt of it. Generally, when I'm practicing, I put this right in front of my computer in the exam room so that when the suicidal patient does come in, I have exact questions I can ask, and I remember the exact process to keep me most efficient with my time. So now the next few slides, if you look at these boxes, the next slides, we've already gone through suicide screening, so we're going to go through each of these to help determine the difference between each of them. So suicidal ideation versus non-suicidal ideation. So the reason why it's so important to distinguish between these two is because what we know is suicidal ideation is strongly related to suicidal behaviors more so than non-suicidal morbid ideation is. So if someone is just thinking about death, that is less predictive of them actually attempting suicide than if they were thinking about suicidal ideation. And so we see suicidal ideation associated with significantly higher levels of psychological distress than non-suicidal morbid ideation. So in other words, if you're seeing a patient and you determine that, you know what, it's non-suicidal morbid ideation, you can exhale a little bit because this patient is most likely in a lower risk category. But the next thing we've got to assess is their attempt history, because what we know is that if patients have had 2 or more suicide attempts in their lives, they are at a chronic, higher risk level for future suicidal behaviors. Past suicide attempts are still the most robust predictor of future suicidal behaviors, even in the presence of other risk factors. And so when we look at what the different risk profiles look like for someone who is just thinking about it and has never attempted, someone who has attempted once in the past, and someone who has attempted 2 or more times in the past, not only do the multiple attempters start higher when they begin to escalate, but they finish higher. And we also see, if you look at the next chart, that they escalate much more quickly than someone who has never attempted, and it takes them much longer to resolve and to decrease their distress. So that's why once we've distinguished suicidal ideation from morbid non-suicidal ideation, the next step is to determine, is this person someone who has had multiple suicide attempts in the past? If they have, you should know that objective indicators are better predictors than subjective ones. So objective indicators are things like, would someone likely find them if they attempted again? Do they have access and means? Their survival reaction is sometimes an indirect indicator of future intent. So if they tell you they've tried 5 times and the last time they tried, they sort of felt like, damn it, I can't even kill myself. That's how worthless I am. Now I have to try it a different way. If that was their survival reaction, it's pretty indicative of continued high risk. And if they've got 2 or more suicidal episodes within a primary care appointment, you're not going to assess every single one of those episodes. Your best bet is to ask them about the worst episode that they experienced. In other words, what was the most lethal attempt you ever had, or the attempt that it took you the longest to recover from? Because that gives you a good read of sort of what they're capable of. And then once you've gauged that, you will assess the current suicidal episode. Whoops, sorry, I'm going in the wrong direction there. So in assessing the current episode, you're going to look for factors associated with desire and ideation, and then factors associated with resolved plans and preparation. The whole list on the left correlate to behaviors, and they are, in research, they've been associated with behaviors and actually attempting, whereas the ones on the right are not quite as predictive of behaviors happening. But if you have 2 or more factors of suicidal ideation and desire, which is on the right side here, then you'll want to become concerned. If you have 1 or more of the resolved plans or preparation, you want to be concerned. Now, let's superimpose the objective and subjective versions of this, just in case you happen to be dealing with someone who has attempted 2 or more times. Note that looking at how isolated they are, the amount of preparation, the planning, having written a suicide note, look at those as really good objective indicators. We're not going to go into that in too much more detail just due to time. One other point about access to lethal means, the idea of assessing suicide intent, it doesn't have any correlation really, or I should say it doesn't have a strong correlation with the lethality. So if I kind of want to kill myself, that doesn't mean I'm just going to take a few pills, whereas if I really want to kill myself, well, then I'm going to use a firearm. That isn't true. There's no relationship there that's strong. And patients tend to have inaccurate expectations about the lethality of their method. So this is why it's so tricky, because patients may think that in just taking a few pills or taking some alcohol with this medication, that it's not going to kill them, but it'll just knock them out for a while. And they tend to be inaccurate about it. How available their means to killing themselves are is strongly associated with lethality. In other words, people will use the most lethal means that they have access to. And finally, we're going to assess for protective factors. The reason why this is important is really for disposition and for treatment planning. So I would discourage you from spending too much time on this in your practice as a behavioral health consultant, because you're not really developing a lengthy treatment plan with treatment goals. You're really functioning to help determine a disposition. So sometimes this will also provide clues for intervention or might prime some positive emotional states. Here's a list of examples of protective factors. I'm not going to go through them each one, but the important thing is don't assume that what you might think is a protective factor, like a spouse or being married, is actually a protective factor. Same with children. Sometimes children are not a protective factor. They are a stressor. So in asking about protective factors, consider using questions that would say, if the patient says, "Oh, I'm married," said, "Well, now you mentioned you're married, so does that sort of add to how you're feeling, or does that help it?" Just so that you understand what protective factors may be present. And finally, we want to talk about how we manage the risk. So the first is that absolutely never make a safety contract. Not only do they not hold up in the court of law, but there is no evidence clinically that they work. Use a crisis response plan, and I encourage you to use the terms crisis response plan because they say that their name technically describes what they do. They are a plan patients can use to respond to a crisis. They function as a decision-making aid. It is essentially a way to help them cope when suicidal symptoms arise. And of course, the earlier they use them when their suicidal symptoms arise, the more effective it will be. Using a crisis response plan is sort of like teaching patients to think something else other than their suicidal thoughts and to feel something else other than their suicidal feelings. It also enhances commitment to treatment for patients, facilitates communication and collaboration. We advise to write it on a 3x5 index card. These days, put it in a smartphone, but it's got to have 4 components. The personalized warning signs, self-management strategies, definitely has to engage others, and some of that has to include professional support. So here's a sample from a patient. You want to help the patient verbalize what that antecedent thought is, what that thought is that comes right before they start thinking about suicide or feeling suicidal. And for this patient, it's, "My life has been a waste and everyone hates me. I'm a burden to John and Bill." So you want to help them develop that statement so that it really addresses, so that it's very poignant and relevant to them. So first, this patient would call Susan. The name's been changed, obviously, but it's a friend. Look through my childhood picture album and Hope Box. If you Google the term Hope Box and the name RUDD, R-U-D-D, you'll find some excellent professional clinical work that's been done with this as a self-management intervention. And it's basically patients put together a collection of items they own that immediately bring about positive emotions for them. And these items are in no way associated with anything negative or even anything ambivalent. So it's a good tool to help teach patients, especially in a primary care domain. Run on my treadmill. So we know that exercise can be helpful for mood enhancement and for reducing the kind of agitation that suicidal patients feel. It's that agitation of I feel all these horrible things, I have all these horrible thoughts going through my mind, and I just feel this urgency to make it all stop. And that agitation often is the tipping point for people to attempt suicide. So run on my treadmill, pet Scrappy, presumably a pet dog, listen to a song that the patient really likes that enhances mood, and then repeat 1 through 5, and then call the person's doctor and go to the emergency department. So it sounds like some folks think that a crisis response plan is common sense. I spend the majority of my BHC appointments doing the crisis response plan. I spend the first 10 to 15 minutes assessing risk and the last 10 minutes on the crisis response plan because this is our main way of helping the patient cope. Whatever is leading them to feel suicidal is certainly not going to be solved in a primary care appointment and probably not in a mental health appointment. And so we've got to help reduce distress and increase hope in the brief time we have with the patient. And of course, we're doing a crisis response plan here mainly for those who are not going to be directly hospitalized from our clinic. In terms of recommending hospitalization, we've actually gone over this already. It's not the gold standard. Post-discharge findings that obviously there are HEDIS metrics around follow-up from psychiatric hospitalization. Sometimes that follow-up is conducted in the primary care clinic, and so we know that there are 25% of patients who come out of inpatient hospitalization, of those who come out of inpatient hospitalization and reattempt suicide, we know that 25% have recently been hospitalized. And of course, because primary care offers same-day, next-day walk-ins, it can be very helpful for this kind of risk management. Transitioning to specialty health. If you're going to refer the patient from your PCMH or PCBH to specialty mental health, make sure you've got some sort of communication back that they actually set up their first appointment. And if they have a wait longer than a week, you should see them for that time in between. So the frequency would be once a week until they're followed up and in care. And that can be by phone, but it goes without saying that developing a network of providers in advance who are ready to sort of hold some acute space for these patients, even if you have 2 or 3 of them on hand and you send them a suicidal patient once a quarter, it's well worth it for the professional network. It's well worth it for the patient, and it will do a lot to quell your anxiety and concern about patients. And then you'll want to make sure you document the follow-up that you've confirmed. Don't assume patients know how to access mental health care. Oftentimes we'll actually help them make that appointment, and so I'm not going to go into this. But educating the patients about the importance of not doing this alone is pretty important. And we've talked about that. Remember that there are no closed cases in primary care. So even if the provider we refer the patient to doesn't work out, we're likely to see that patient back sometime in the future, whether the suicidal episode is resolved or not. And finally, there's a great book out there. This is the only book that I know of that specifically teaches people how to manage suicide risk in primary care and specifically is helpful for people who are functioning as behavioral health consultants within a PCBH model. I strongly recommend and encourage this book. And with that, I think we've got about 9 or 10 minutes left. I will take some questions. Let's see here.
Sure, and I'll remind folks, if you do have a question, you can type it in the question box that's in the bottom lower corner of the navigation bar on your screen, or you can raise your hand and ask that question verbally. Dr. Corso, I sent you at least one question in the chat box. Are you able to see that?
Absolutely. There's a question that came in that said, I'll read it. How do you deal with a patient who states suicidal ideation when seeking medications due to anxiety with depression? So this is fairly common. I think the most important thing is to use the framework that we've just gone over, particularly clarifying, is this actual thoughts of death, or are these thoughts of ending your life or enacting that death? And does the person have a history of multiple suicide attempts? And trying to understand how they've handled it in the past and what's happened. Certainly, if they're seeking medications, I would want to know if you had any prior bouts with suicidal ideation or any prior suicide attempts, were you taking medications during those times? So that I can sort of gauge how different is this situation than prior ones and how helpful was medication. In general, there's no literature I know of that would discourage someone from starting pharmacotherapy treatment for any reason when someone says, well, I'm suicidal, but I would also like meds. I'm not aware of any literature that would discourage it. I do know that Zoloft is a very safe antidepressant to start people on when you know there's suicidal ideation, because essentially they haven't found a lethal dose yet. In other words, you can take up to, I think it's 3,000 milligrams is what they've tested, and still it's not led to death. Of course, the starting dose is 50 milligrams. So that's something to be aware of. I would be careful if they're requesting benzodiazepines, and I think you also want to be careful about your scope of practice as you address medications, but according to the literature, the best treatments for long-term anxiety are not the benzodiazepines, they're SSRIs, which hopefully, unless there's some contraindication, the PCP would be prescribing anyway to address the depression. So I hope that answers the question. The way I look at situations like this is and the way I talk about them with patients is that I would rather use more tools in my toolbox than less. And if you feel like medication is a tool that's going to help you in addition to the other assistance we're going to give you, then your primary care provider thinks that it's a good fit for you, then I would support it. There were other questions that related to having a copy of a suicide screening form. Not sure which suicide screening form we're talking about. If it's the schematic, sort of the flow chart, that's available in, whether you use Google Scholar or Ovid databases, whatever primary literature search tool you use, that's available from it's actually called Professional Psychology Research and Practice, and the citation is Bryan, B-R-Y-A-N, Corso, Neil Walden, and Rudd, 2009. If folks are looking for the other screening forms like the BHM-20 or the PHQ-9, the PHQ-9 is free. The Columbia scale, which is the one I would most strongly recommend, it is available, and to be honest, I don't recall if you have to pay for it or not. But I know that if you're running clinical trials and doing research, there's a lot more leniency in using it. But I don't believe you have to pay to use the Columbia. I'm fairly certain it's free. And the PHQ-9, of course, is free. Things like the BHM-20, which was another questionnaire that happens to have a suicide item on it, that is proprietary and costs money. There's another question here from a attendee that said, I've been taught to always call a crisis number or 911 first on the crisis response plan, whether or not it's actually the first step. So that if they do kill themselves, the documentation looks like we gave them your highest level of support first. That's a great question. There is a lot of misunderstanding about malpractice and what it looks like. The two factors that contribute to whether someone is deemed to have committed malpractice or not is foreseeability and standard of care. So foreseeability means, did we see what was happening? And so if the patient, if in the note it says patient reported suicidal symptoms and we didn't call them suicidal symptoms, diagnose them as suicidal symptoms, or even address them, then we are making an error of foreseeability. If the patient didn't say anything at all about their suicidal symptoms, then we are not, it wasn't foreseeable and we're therefore not responsible for it. I mean, ultimately as their providers, we might be investigated, but foreseeability is the first thing. Did you see it coming? Did they report something? And then the second component has to do with the standard of care, and that is, what would your other reasonable peers have done in that situation? And I know of no literature that says a crisis call number or 911 has to be first. In fact, it's probably the opposite. If you look at the Bryan and Rudd book that I recommended and some of the other literature, you want patients to be using increasingly intensive interventions, starting with self-management ones. So I generally do not train clinicians, whether they're PCPs or behavioral health consultants or providers. I do not train them to put 911 first, because then I'm not teaching the patient how to self-manage themselves, and I'm not aware of any legal or clinical evidence that it should go first, that calling 911 should go first. And those are all the questions I see here. I'll defer to Polly.
Yeah, I think that's all the questions that I've seen come through at this point, and it looks like we're nearly at the end of our hour. I did want to thank Dr. Corso for the presentation, the thoughtful presentation today. And as a reminder to all of the people on the call, a recording of this presentation will be on the CFHA website in the next few days. And as one more announcement, if you were interested in this webinar, you may be interested in our May webinar, which is also sponsored by the PCBH Special Interest Group. The title of that webinar is Brief Interventions for Anxiety in Primary Care Behavioral Health, PCBH, and it will be Wednesday, May 11th. From 11 to 12 Eastern Time. We will put registration for that up on the CFHA website in the next few days, so be on the lookout for that. Again, thank you to the PCBH SIG for coordinating this, and thank you, Dr. Corso. Have a wonderful afternoon.
Thank you.